Thank you all for coming. I want to thank Jim for inviting me here. I'm very excited to be working closely with the Center for Public Health on this very important issue. I'm very excited to be speaking about it today. Oh, yes, sir. Let's just bring this presentation up here. Get this started. Thank you all for coming. If you didn't catch up before tonight. Very excited to be here speaking about this very important issue today. And I'd like to open my presentation with a quote from a very smart man, Albert Einstein. This quote's been rewritten and presented many different ways, but they all say essentially the same thing. He suggests if he had an hour to solve a very important problem, he would spend 55 minutes focusing on understanding the issue, and then 5 minutes proposing solutions. I really like this quote because I think it reflects if you want to solve a problem, you really need to understand it first. And I also think it relates very well to the issue of anabolic steroids and enhancement drugs, because I think a lot of the situation that we're in today has to do with a rush to fix an issue that was poorly understood at the time. So let's get into it. I want to start with a little background information for those that aren't very familiar with anabolic steroids and what these drugs are. These drugs are all based on testosterone. It's the primary male sex hormone. Has many actions in the body. We generally categorize them in three primary classes of action. Anabolic, testosterone builds muscle. It's the primary reason why men carry around more muscle mass than women. They have a lot more testosterone. It also helps with calcium retention in the bones, increases red blood cell production. These are some of the anabolic class of testosterone. Now there's another class of activity, androgenic. This is the masculinizing effect of the hormone. Secondary male sexual characteristics, deepening of the voice, body, facial hair growth, those kind of things. It's also very important for male libido and male fertility. And it also actually is very important for females as well in that area. Separate issue. And then testosterone may seem a little unusual to people, but is also responsible for most of the estrogen that's found in the male body. And estrogen is very important to men as it is to women, although we don't regard it as a primary sex hormone. But it's very important for a lot of things, also in sexual function, has effects on metabolism, and also some anabolic effects of estrogen as well. So these are three primary actions of testosterone, and there's some others, but this is what we're focusing on when we're talking about anabolic steroids. So let's look at the history of drug development. You know, in 1931, scientists first synthesized testosterone. They were able to replicate it and turn it into a drug product. Within a few years later, 3 years, they had Proveron, which is an oral steroid. It was the first effective oral medication. The thing about testosterone is you can't swallow it in a pill. Body just destroys it. So in the early years, and in the 40s and 50s, we started seeing a lot of work with getting these drugs into medical use and developing, more drugs with different activity. Really what scientists were trying to do in all those years is alter the characteristics of testosterone to make it more applicable in different spots. For instance, with treating women and children, the androgenic side effects, or the androgenic effects are a concern. So they tried to develop purely anabolic drugs, drugs that would only build muscle and have the positive effects in that regard and not secondary characteristics. There's also a lot of work with changing the bioavailability of testosterone. Again, you can't take that orally, so they found all sorts of different ways to either inject testosterone and make it last in the body or to modify it so it can survive digestion. And also the estrogenic effects of testosterone. There's ways to alter the structure of the hormone so it does not convert to estrogen at all, and gives us some other, set of potential benefits for therapy. So, with all this development, we see a lot of different steroids. And again, this is because, at least at the time when they were developing these, they saw a particular use that could be better met with one compound as another. I'm not going to go through all the different steroids, but these are just some of the popular ones that you'll come across. The testosterone we have this big list of anabolic steroids. Probably about 2 dozen or more are in widespread use in medicine. And they're used for a number of things. The primary use, initially was to treat men with low testosterone. There's a lot of side effects when you don't have enough androgen levels. We'll get into that in a minute. And then they started finding other uses for it, treatment of osteoporosis, wasting disorders, tissue healing. We're still looking at that, like treatment for burns and things like that. Breast cancer, it's not widely, steroids are not widely used for that purpose today. Use better drugs, but for a while they were also quite commonly applied for that. So these are medicines. Like all medicines, there's potential side effects. So let me just run down real quickly without getting too deeply into them. There's a bunch of different areas that we focus on these effects. One of the main ones is cardiovascular. Scientists realized pretty quickly when you increase the androgen level, when you're taking anabolic steroid, there's a shift in cholesterol balance, typically an unfavorable shift. The HDL, or good cholesterol, goes down, the LDL may go up. Over time, there can be a thickening of the walls of the heart. You see that typically combined with high dose steroid use in powerlifting or heavy weight training. Steroids increase blood pressure. They can slow the clotting ability. So very often you'll read the prescribing literature if you're going for surgery or something. They need to look at stopping anabolic steroids if you're on that therapy because it could interfere with heal from the surgery. There's a lot of reproductive potential side effects. They can interfere with fertility. Tightly regulated process that involves the production of testosterone, and when you start taking hormones from outside, it can definitely start interfering with your natural production, which can lower our sperm count, interfere with sexual function. Now, when you're taking an anabolic steroid from an outside source, your body stops its own production of testosterone or lowers it. So we say that hypogonadism or testicular atrophy are common side effects with anabolic steroids. Of course, testosterone taken from an outside source corrects hypogonadism. So that's why it's commonly treated for that. And women that take anabolic hormones, because they're male hormones, they can interfere with their reproductive system as well. Very common menstrual irregularities and some other issues we'll get into. Liver toxicity. Just want to emphasize this is related to oral anabolic steroids only. In order to get testosterone to survive digestion, survive in the liver, they came up with some chemical modifications. They work very well for allowing the steroid hormone to get into your bloodstream, but it does tax the liver a little bit. So there is some toxicity, but again, it's just related to oral compounds. Okay. There's a bunch of cosmetic issues, gynecomastia, breast tissue development from too much estrogen, androgenetic alopecia, pattern hair loss that are related to steroid acne, or fat retention. Some psychological issues, sometimes depression, typically at the conclusion of using the compound when your hormones are getting back into gear. And there's a clear link with aggression and testosterone. Now, women, I'll just touch on this again quickly. These are male hormones, so women that take anabolic steroids are at risk, dose and compound dependent for masculinizing side effects, body, facial hair growth, clitoral enlargement, vocal changes. And this does happen to men to a much smaller degree, but women can definitely notice a dramatic change in vocal pitch. These side effects are generally regarded as permanent, so it does make for an issue we need to be much more careful with these drugs. And I want to emphasize things that are not supported by the medical literature at all. A link between anabolic steroid use and suicide. This concept of roid rage, that a normally sane, rational person can take an anabolic steroid and go out and commit a murder or violent act, that is also not supported by the medical literature. Or the idea of other 60s, 70s, and 80s, anabolic steroid use becomes extremely popular. It spreads like wildfire. We see it through sports, bodybuilding, and it even crosses over into non-competitive people, non-competitive bodybuilders, just people that are looking to build muscle. So I'm sure you can all see the train wreck that is coming next. 1988, global steroid health crisis. We reached critical mass in anabolic steroids. Competitors were dropping dead on the field. That year, more than 24 major sporting events were canceled because there were just not enough members on respective teams to pull a full team together. There was that many people sick. Hospital rooms absolutely flooded with patients coming in with new problems with steroid toxicity. Very, very strange time. Now I see some confused looks. That is very good. Because of course, nothing like that ever happened. There was not in 1988, there was not today, there was not 10 years ago, there has never been a health crisis in the manner that I just described. These drugs are very popular, but competitors aren't dropping dead on the field. Teams are not falling off competitions. Why is that? Why are these drugs with these potential side effects, why aren't we seeing this? And what really happened? Why are we in prohibition today? The real issue is doping. It's the issue of ethics in sports. In my country, the big tipping point was the '88 Olympics. Ben Johnson, Paul Lewis, American favorite Paul Lewis, he got beaten. Ben Johnson, who later tested positive for anabolic steroid. Huge scandal. I can't speak for what was happening here at the time. I'm sure there were other popular doping scandals as well. During the 80s, we heard a lot about this. There was a lot of outcry in the media. There was a lot of supposition. People in the media don't really understand these drugs, are very new. Read off the side effects and start saying, well, these are terrible deadly drugs. Parents are getting all upset about their children taking steroids. So politicians rushed to act. We instituted prohibition policies. Now in my country, we had a series of hearings over the course of a few years. Frustrating politics in the U.S. in spite of the fact that experts from the Drug Enforcement Agency, Department of Health and Human Services, the American Medical Association, various medical experts that came in, they testified in front of Congress. And the testimony was pretty much in sync. They were pretty much in sync with one another. These drugs should not be criminalized, which is, of course, what we went ahead and did anyway. We criminalized possession and, increased all these penalties on the trade for steroids. Now, here's a quote from Dr. Usalis, who was asked to testify. I like this. I like this quote. I think it sums things up well. He's talking about the loss of credibility. And he's saying, we're telling people that they're going to be dropping over dead, and athletes are looking at long-time users and not seeing people dropping like flies. Now, as he states, increased death, probability of death and morbidity could be taking place, but they are not dropping dead like flies. So, was Dr. Usalis wrong? No, he was spot on. Now, as sure as I'm standing here today, I'm going to explain what the medical literature supports in terms of the health risks of anabolic steroids. In an acute, short-term sense, these drugs are very safe. They're hormones. No risk of overdose, there's no physical addiction. They're non-toxic, barring what we know about liver compounds. And it's exceedingly rare to have a life-threatening reaction in the short term from anabolic steroids. And when we're talking about short-term side effects, we're typically talking about cosmetic issues or temporary issues. Remember, it changes to cholesterol we talk about, blood pressure. Those are temporary. They go back to normal when you stop taking the drugs. The main issue when we're talking about health risks is long-term abuse. It's letting those shifts to your cholesterol, the changes to your vascular system, and it's letting those changes go on, unchecked for years and years, and then we're talking about potentially what it looks like to be. We don't actually have the data to support it, but logically we think there's a significant increased risk of cardiovascular disease, heart attack, and stroke for the long-term steroid abuser. And also hypogonadism, low testosterone, which is also important for health. We'll get into it later. suggestion that the long-term steroid user, after getting off the drugs, may have some issues maintaining the same optimal level of hormones as other people. But this is what we're talking about in progress. We're not talking about somebody using the drugs for a year and then dropping dead of a heart attack. And when you see something like that, again, it's very rare, and you need to look at the medical history of somebody before we rush to judgment. This is just the short-term doom and gloom scenario just never occurred with these drugs. Now, some people may think, maybe I'm a little nuts saying this, I don't know what I'm talking about, but I want to bring this report. It just came out a couple months ago from Australia, and this is from the Department of Forensic Medicine. Now, when there's an unusual death of a young person, or just an unusual death that can't be explained in Australia, like in many other places, the body goes in for autopsy and they need to figure out what happened. In this case, they were looking at young people that had died very muscular, so they started looking at anabolic steroids to see if they could find a link between these strange deaths and anabolic steroid use. So this paper came out, and they report 24 deaths where they had uncovered anabolic steroids between 1996 and 2012. Now, first off, I don't mean to seem callous at all, but it's 24 deaths in 16 years. It doesn't sound like an enormous crisis to me. Now, granted, nobody wants anybody to die necessarily, but those aren't epidemic numbers by any stretch. But then we can look at the data a little more closely, and it just gets worse from there. Because let's look at the reasons for death in these cases. Accidental drug toxicity, 54%. I mean, there's no overdose with anabolic steroids. So what happens? Where is this coming from? And we see homicide, suicide, accident, undetermined. None of the people actually died from simply a heart attack or something that we would logically look for if you're looking for this kind of effect on anabolic steroids. Then we look at the toxicology. In only one case of 24, they only found steroids. Just about everybody else had other psychoactive drugs, opioids, stimulants, cocaine, amphetamine, benzos. So in Australia, when they're talking about death from anabolic steroids, they're not really talking about anabolic steroids. They're talking about other drugs. They're talking about homicides, accidents. The one thing we can pull out from this report, which is an interesting statistic, is that 47, almost 50% of these relatively young men did have signs of cardiovascular disease. This is what we do understand of anabolic steroids. Logically, we believe that they can increase this likelihood over time. So there's some interesting data that we pull out of that, but 24 cases, only one of them only had anabolic steroids in their body. This is a terrible argument for the criminalization of anabolic steroids, and in Australia, they're just going really strong in that direction. Recently, they passed a law that changed the penalty for possession and sale, I believe, to 25 years. So, not very good for the sport. So, let's take a look at prohibition for a minute. I'm going to think about this. We've been in this prohibition phase dealing with anabolic steroids for more than 20 years now. And prohibition takes on many different forms. One of the first and most dramatic things that government started to do is focus on preventing the diversion of pharmaceuticals, stop them from getting to the black market so bodybuilders and athletes can't use them. Stop physicians from prescribing them for non-medical purposes. Ban importation, and of course in some countries, mine, I'm sorry to say, leading the world and trying to export it as much as possible, criminalizing the use and possession of anabolic steroids. So this is how we've been dealing with the problem for 20 years. And I'd like to focus a little bit on what the result of that has been. For one, prohibition, enormously successful at limiting the diversion of pharmaceuticals to the black market. Phenomenally successful. I would estimate, and these are just, crude estimates for myself, but I estimate that now 90% of the drugs on the black market are illegitimate. They're either made in the underground or they're kind of versions of real pharmaceuticals. 10%, probably less at this point, I would say, actually came from a real pharmaceutical manufacturer. What do we have instead? We have a dramatic market shift where raw materials are shipped steroid products from there. And incidentally, the UK is a major hub of this. You guys are exporting a lot of underground finished products. This is what an underground lab looks like. Just a few pictures. The chemist is weighing out some powder here, some materials he's mixing up with, heating it. This is post-filtration. Finally, they're putting it in the lab. I'd like to say this is actually typical, but it's not. This chemist actually had a chemistry background, was very concerned about product quality. You can see he's wearing a full body suit. I don't think most underground labs would go to this level. And still, this isn't pharmaceutical, standard by any stretch. This one was actually an air filtration, so things you don't typically find in the average underground lab. And these products are typically labeled as underground products. You'll see Full Muscle Labs or some other name that doesn't really ring true as a pharmaceutical company, and most of the people purchasing on the black market know these are underground products. They still use them. And what's not an underground lab is typically a counterfeit product. I put two pictures here. One is the real. I forget which one's the real at this point. So one of these is the real product, version of Winchell, one of the counterfeit. Very sophisticated counterfeiting at this point in time. I just last week spoke with a contact of mine in Portugal, and he's insisting there's now 5 copies of the same product. One looks better than the other, and they're all absolutely perfect. So, we've cut off the legitimate supply of pharmaceuticals. We're filling the demand with underground product and just copying what, whatever else. And it's, and you may think to yourself, well, what does it really matter? Steroids made in a pharmaceutical facility or made in an underground lab. It makes a very big difference. We take for granted that when we walk into the pharmacy, we're going to be handed a product that, 1, contains exactly what's on the label. 2, there's nothing living in it. And 3, there's nothing else in there that's not on the label. There's no contamination. It's a clean, sterile, properly dosed drug product. It's not what we're finding on the black market these days. 2005, Harvard Grant did a really interesting piece. They ordered 12 products from 3 internet steroid dealers and sent them right into the lab. What they found was pretty alarming. First, none matched label claim. They were either underdosed, overdosed, had other steroids in them, or no steroids in them. Look at some of the additional contaminants that they found. Arsenic, tin, lead, heavy metals, prednisone, corticosteroids, no business in there. Another one. Actually, synthetic estrogen, benzoyl chloride, industrial processing chemicals, strange stuff you really don't want to be injected. So I followed up with this myself in 2010 for the book Underground Anabolics. I took 24 samples that we purchased off the UK and European mainland black market, sent them into the lab, and we found similar problems. First off, 6 of the samples, 25% had bacterial contamination, which right off the bat is a considerable problem. But we found other things, DHT, phthalates, long-line kerosene, some other intermediary compounds. All in all, actually, it wasn't as terrible as you saw with the Hartford drink, but it's clearly not pharmaceutical quality product. Nobody's going to advocate that we should be injecting bacteria, but this has become a significant problem with this underground manufacturing. And there was another case too. I'll just bring this up. It's not a definitive case of heavy metal poisoning due to underground product, but there was a recent issue in Australia. I believe this is actually one of the undetermined deaths, or the undetermined death from the other study we mentioned. But a 35-year-old walked into the hospital, sick, nauseous, definitely showing some kinds of signs of toxicity. Probably assumed at the time it was related to oral steroids. In any event, the gentleman brought in all his protein powders and steroids and ancillary drugs that he was taking. So they started treating him for supportive care, liver toxicity stuff. But he kept progressively getting worse. And then he started showing signs of neurological issues. So they suspected heavy metal poisoning at that point, tested him for that. 33 times the safe level of arsenic was in the patient's blood. They tried to get some more supportive care to deal with that, but they were unsuccessful. The patient died. After they tested all the stuff that he brought into the hospital, they found 2 unlabeled vials with liquid inside, and one of them, they didn't find a steroid, but they found a very high concentration of arsenic. I bring this up because if this is an issue of, dirty product or, dirty underground compound, this would be a death cause clearly by prohibition. It's not a death of steroid use, this is a death by what we decided to do with the market. So I think that's very interesting, and it reminds us that prohibition does have a cost as well. And if not this case, this will come up. So, what else does prohibition do? We prevented prescribing for non-medical purposes. That may seem logical, but what is the result of that? There's no physician oversight or advice anymore. You can't go to your doctor and do an anabolic program. Granted, a lot of use was taking place in the black market before prohibition, but there were, at a time, physicians that would specialize in this type of thing. That you can go there, get your blood work done, and they would work with you and monitor you. There's no possibility of that. And at the same time, that will also mean minimal focus on health markers, blood testing. People are doing all of this on their own. And of course, it also means they're not getting advice from the doctor, they're getting advice from the gym, from their friends. And I've seen a strong trend for this over the years. The doses are going up that people are recommending. Enormously high doses that beginners shouldn't be taking are very commonly recommended nowadays. Longer cycles, the concept of they call bridging and cruising, which bridging is using a small dose of the same thing. This is really on all the time steroid use, so they're not technically cycling at that point. A lot more use of spot injections, so it can be much more tricky, more prone to problems, and more injections generally. When these doses go up, these people are obviously injecting much higher volumes, they're doing this more frequently, and this of course increases the risk for issues. What else are we seeing with prohibition? Well, the supply is no longer controlled by drug companies and government rules. So it is now a market free-for-all. The drug producers are underground dealers. They put in whatever they feel like and whatever they think will sell. They're catering to marketing it to their clients, so we're seeing much higher concentrations. Unapproved steroids, designer steroids. There's certainly no approval process or nothing that would prevent one of these companies from doing it. We've seen a lot of it. Blends, pre-stacked products. Put a little bit of this, a little bit of that in, and you don't need to take 2 products. You have everything in one. But of course, these are all new concepts in terms of, these were never approved as drug products, and we're kind of just doing this on the black market. And these are still generally in the Q sense safe drugs, but there's an approval process and Food and Drug Administration for reasons. And this compound in particular, methyltrianolone, it's the most liver toxic steroid that was ever tested in humans, and they pulled that very quickly from consideration, but now it's back in the black market, not completely. And the big question, what is prohibition doing to the usage of anabolic steroids? Well, of course, the answer is we don't know. This is a relatively new phenomenon. I call these old drugs because we've had 50, 60 years experience with them, but in terms of dealing with this issue, it's a relatively new phenomenon. So we don't know, were it not for all these policies, how many people would be using steroids today. However, we do have an idea of how many people are using steroids today, and it's a lot. This was a recent meta-analysis. They looked at 70-some-odd studies. The meta-analysis, they try to bring all the data together, weed out what's unreliable, and come up with a consensus in the data. And what they came out with is that it's about a 3.3% lifetime prevalency rate. Breaks down to almost 6.5% for men and 1.5% for women. Seems a little high to me, but this isn't my area, especially at the epidemiological studies, is my area of specialty. So even if they are, these numbers are a little inflated through questionnaires and the like. This is very significant. We are positive that these numbers are much higher than pre-prohibition. Back when this whole thing started, most of the people using them were athletes, competitive bodybuilders, and there's so many more people using these drugs. It'd be nice if we had some real solid numbers, but clearly prohibition hasn't resulted in this issue being pressed down and for steroids to be somewhat under control. These are very popular drugs. So this is what we've got. This is what we have from 20 years of prohibition. We have a decimated steroid supply. That's been very effectively done by these regulations. Because of that, users are at a much higher risk now of infection, contamination, just generally health issues because the drug supply itself has been so corrupted by these issues of contamination and mislabeling. We've diminished access to medical advice and blood work, all for an unknown effect on the prevalence of steroid use. Let's just say, for argument's sake, that there is some reduction. It seems logical that were it not for all these issues with having access to them, or in the case of countries like mine where it's criminalized, maybe the use would be a little higher today. Maybe. But this is what we're trading for. Everybody else that continues to use these drugs is now at much, much greater risk. So we should be asking ourselves if this is really a recipe for reduced public harm, or if it's causing more. Another quote from Einstein: "No problem can be solved from the same level of consciousness that created it." Again, 20 years we've been thinking like this. This is the solution. And the problems are just getting worse. So maybe it's time that we start thinking about things a little differently. So what can we do moving forward to make this a safer environment for everybody? For one thing, we absolutely have to quantify the risk, particularly the long-term risk, because we know the short-term risk is relative, because it's very low. We need to quantify the risk of steroid misuse, steroid abuse, because supposition is all we have at this point. We suppose this is very unhealthy because of what we see in the short term, and we suppose that you're going to have a heart attack earlier if you do this. I mean, it makes logical sense, and there seems to be a lot that supports that, but we need to quantify this. I can stand here and I can give you all sorts of statistics. I can tell you, and it's not my area, so I didn't bring them up, but I can tell you the likelihood that someone will be addicted if they use a substance, or the likelihood that someone will OD over time if they're using a substance. I could stand here and give you statistics on how much time each cigarette will take off your life. But there's nothing like that for anabolic steroids. We absolutely need that. Researchers, clinicians, we need to work together to collect and analyze this data. This data is out there. We just have to find it and sort it. I mean, we've been using these drugs. They've been widely used for sporting purposes for over 50 years, so it should be out there. And we should also look at the risk for athletes versus bodybuilders, because if we're going to find the long-term health risks, we're probably going to be more inclined to find them in the bodybuilding population, which uses higher doses, more likely to use multiple drugs, than in the athlete populations, which are, use them often, single compound for shorter periods of time or in their athletic careers. So these are definitely some things we need to come up with. And I know there is starting to be some work in this area quantifying the cardiovascular risk. We really need a lot more of that. We also have to quantify the black market risk. I think most users today understand that there's an issue with the drug supply, but we need to be giving them solid numbers. We need to let them know that, at least in my case, it was 1 out of 4 products was contaminated with bacteria. We need more study like this so we can come back and give some, again, some solid numbers so people can understand and quantify the risks that they're taking if they're going to buy on the black market. I also think we should look at new equipment. I think it would be really good for needle exchange to take a look at syringe filters and sterile vials. Again, bacteria is a big problem. A proper, 0.22 micron syringe filter will remove all bacteria from a solution. There are some limitations. It can't remove other drugs. Pyrogens, which are bacteria, fever-producing compounds that the bacteria may produce, or heavy metals. But it can address at least the issue of live bacteria in these solutions. Of course, there is the other side of it where you're breaking open the seal on a sealed vial, and and transferring it to another one, which could introduce bacteria to it. So this is something I think that at the very least needs to be investigated and looked at if it is viable. Now, this is also, I think, very important. We need to address the concept of self-medicating. I know we've heard it time and again with other drugs. This is a very substantive debate here when it comes to anabolic steroids because, look, as men get older, our hormone levels decline. We've come to find in the last 5 to 10 years that this is a significant health concern for men. It increases the risk of cardiovascular disease, diabetes, osteoporosis, there's physical issues with it, sexual issues. So there's been a drive. One of the good things in steroid policy that my country has been leading on is getting older men into treatment for low testosterone. There's very valid, and I invite everybody to look up the data, very valid use for testosterone for men aging, and it does, in many cases, protect health and could extend life. So what I believe that you will find is that some portion of the men that come into needle exchange are actually self-medicating. These are the men that are older. They're probably going to say they feel like crap when they're not using their compounds. They're probably using or possibly using moderate, low doses of stuff. They want to feel good, look good. They want to feel vibrant. This is a normal, valid concern for everybody. And this is a rapidly growing area in medicine. And I think it would be nice to see if there could be a percentage of people that come into needle exchange that actually could be deferred to physicians to handle hormone replacement therapy. They have a clinical need for it. I also want to mention allocation of resources, just very briefly. I don't understand exactly how the budgets work with needle exchange and stuff, but I urge those that do focus on this to not just look at this as a numbers issue in terms of how many people are in needle exchange. There is a lot of overlap. There's the main concern, which is reducing the spread of blood-borne virus, proper injection procedure. A lot of that is overlap, but there's a lot of also separate issues in regards to anabolic steroids. So I would urge those responsible for making these decisions. If you see a large influx of steroid users in a particular clinic, make sure they're funded properly to deal with that, and you're not just shifting one from the other, because you don't want to draw from your other narcotic interventions to deal with this. You really want to focus on this independently with its own budget. And on that note as well, if you can in your budget, I do recommend, if you can add somebody to needle exchange that is a weightlifter, former steroid user, this can go an enormous way in connecting with your clients. And of course, this is in addition to the standard blood-borne virus stuff. I'm not suggesting that that this takes the place of that, more as this is an extra level of counseling. Because if you can really connect with these people, get them talking about what they're doing, their doses, the risks that they're taking, and really get some good dialogue in, I think it will go a long way to shaping their decisions and helping them make better choices. And lastly, I do think that it is time we rethink some policies in regards to how we deal with this issue. I mean, for one, easing restrictions on imports. I can only assume the recent change in UK law had to do with the ease that people were ordering stuff over the internet. But what does this do? This just cuts off the last supply, the last legitimate supply for people that were astute enough to find legitimate suppliers in other countries where they don't have such controls. Now they can no longer order that, so once again, that user is now forced to buy from the local black market and deal with the underground issue. Recovery agenda, there was some talk with me about this a couple years ago. I don't know exactly where that is, but I strongly urge, don't look at anabolic steroid users with the idea that you need to get them into recovery and off steroids as quickly as possible. I think that this is a mistake. When you have the steroid users in needle exchange, this is where you want them. You want them in needle exchange. You want them with an open dialogue about what's happening. This is how you can reach them. And this is, for most people, this is a lifestyle choice. This is not a a life-destroying addiction that they're struggling with, and for the most part, they're not going to be very open to the concept that they need to stop right away. They're doing something terrible. They've already made the careful decision to use steroids. They understand there's some risks. You want to keep talking to them. You want to keep educating them on it. You don't want to push them out with some kind of rehabilitation program that's not suited for steroid users. Of course, to underline, you should not ever criminalize personal use. That has just been a disaster for the United States. It causes so much added issue with families and personal issues, and certainly not solving the problem. We've got very high numbers of users as well, and criminalization doesn't seem to be accomplishing very much. And I'm going to leave you on this concept, and it may seem completely ridiculous to some people, but just ask yourself, why can't we allow doctors to prescribe steroids for muscle building purposes? Why not? We as a society allow cosmetic surgery. What is cosmetic surgery? Medical intervention for no sake of medical needs, for vanity purposes, for cosmetic purposes. We allow this. 1 out of every 5,000 people that gets liposuction dies, largely a result of anesthesia, but we accept this. Why are we not saying non-necessity medical procedures? Why are we banning that? And this is a significant risk. 1 out of 5,000 people is going to die that does this, but we accept that. So I just want to leave you on that. There is another way to look at this, and from my personal estimation, getting this whole issue back in the hands of doctors, holding the physicians responsible if they're mistreating their patients and giving them abusive dosages, that is a much, much better way, or potentially a much better way of dealing with what we've been doing now, which, as we have seen, hasn't done a whole lot for getting rid of the issue and has done a whole lot to increase the risk for those that continue to use. That's my presentation. My contact info is up. If anybody would like to email me, I may have time for a question or two.